Now we're going to get into a panel, and it'll be a quick one. It's on data analysis and business intelligence for healthcare resource planning. I'd like to call the panelists to join me here at the center. Preston De Swardt, Executive Retail Industry and Health at Telkom. Dr. Sean Broomhead, Chairman, African Center for eHealth Excellence. Dr. Vincent, Executive Director, Health Information Systems Program, Jonathan Mills, Founder eHealth News, and Taru, Simbi, Director, Healthware Africa.
Sean, I'd like to ask you to do some opening remarks. The topic is data analysis and how they can actually be harnessed to deliver benefits, whether they be organizational or for outcomes in clinical setting. And in your work, you interact constantly with organizations collecting data. What is the potential of that data?
You kick us off to exactly the right start, because potential is a loaded word, and I think it's an important word that we deal with just for a minute or two before we get into the data analytics topic. And it's a great way into the topic, because we've been talking a lot about potential this morning. There's a lot of agreement around the world that there's huge potential in eHealth. But there's a paper out of the US today, in fact, put out, it's a statement by the American Heart Association. It's about a 58-page statement, and they're dealing specifically with the difference between potential and probability. And they're saying eHealth needs to shift on from talking about potential and start talking about probability. And that forces us to deal with some really hard questions and some really hard issues, because the initiatives that are probable to succeed are quite a shorter list than the initiatives that have huge potential. So that's a first comment. But I think there's something else I'd like to talk about. The Seattle Children's Hospital is known to have one of the best analytics systems in the world. And the guy that runs it is a guy called Eugene Kolker, and he's regarded as being a fantastic informatician, so a real techie. And when he talks about data analytics and he gives advice to people on data analytics, he says three things. He says, first, worry about people. Second, process. Third, technology. And this, I believe, is at the heart of what a lot of the conversations were about this morning. It was about bringing people in at the right stage, about taking technology to people in the right way. But Kolker's much more dramatic than that. He says, before you even think about technology, look at your people, build relationships with people, understand what they want, understand what they're trying to do, whether it's your doctors and the way that they relate to one another, or other healthcare workers, or all the patients. But deal with the people and understand what their objectives are. Then start looking at the processes that are needed to support them, and then find the appropriate technology solution. And this applies equally to analytics as it does to anything else. And then perhaps a final point just to make about analytics or big data, as it's sometimes referred to. I prefer calling it analytics. Yeah. I think the people that do this seriously talk about 5 levels of analytics. 1 to 5. 1 being the most immature and 5 being the most mature. 5 is where the description is you've reached analytics nirvana, which I think is perhaps a little bit tongue-in-cheek. But it's the point where it's not just that your analytics is a fantastic support for your strategy, but your analytics is driving your strategy, that you reach that level of sophistication. And then level 4 is one level below that, where analytics is a very powerful tool. It's used deeply, and it's an important part of how your organization chooses its strategy, but it's not yet driving the strategy. On the other end of the spectrum, the level 1 is where you're really making decisions intuitively. Whether it's about your hospital or your clinic or your healthcare system, you may have a little data, but you're not really using that data. You're making those gut decisions. And strong leaders and strong managers actually do surprisingly well off those gut decisions, but they're not using data at all. Level 2, you're starting to use data, primarily through reporting, but they're in silos. There's not good integration across the data, and the analytical potential of that data is extremely limited. Yeah. Level 3, you haven't moved beyond 2, but you've recognized that you would like to, and you're starting to struggle with how you'll do it. There may be people in the room that criticize me for this, but I'd say by and large we're at level 1, 2, and 3 in African countries. Different organizations are at different parts of those, so there's not uniformity across any country. Large parts of most countries are at level 1. Some are starting to move into level 2, get the reporting in place, starting to see good reporting systems flowing through, but those reports are not integrated, and the ability to do decent analytics off it is very, very limited. And then there are pockets that have recognized the importance of getting properly integrated systems and integrating their reporting systems and starting to be able to run analytics off that. They're testing, they're playing, they're exploring, they're struggling with how they're going to put this together. I'd venture to say there are very, very few organizations on the African continent that are at level 4. Back to Eugene, I'll close with this. Kolka, his organization is at level 5. What they use analytics for is they use it as to compete as a healthcare provider, and they compete on health outcomes. So they compete as a healthcare provider on their ability to improve health outcomes. And what kind of things, what are we talking about here? It's infection control in ICUs. It's infection control in theaters. It's breastfeeding in neonatology. It's decreasing your 30-day comeback in neonatology. It's really hard, crunchy things that they're using their data for. It's not esoteric. It's not something that's far removed from the real service industry. It's making real immediate impact on the way health providers work and how they improve the condition of their patients and save lives.
Vincent, I'm going to turn it over to you to sort of expand on that a bit. You, with your organization, you work across Africa and parts of Asia as well. But before that, I understand even in your own clinical practice as a physician, you worked in numerous countries. So you've seen different states of healthcare all over Africa. Now, as Sean alluded to, at that level 5, they're all focused on outcomes, but that even applies to the intuitive doctor down at level 1 who's still trying to deliver the best outcomes. And so throughout all those different levels, you know, regardless of where the settings are, do you see potential as well as probable examples of where analytics can be used already to improve outcomes across Africa?
I'll start at that because I think that's a good starting point to follow on from what Sean was saying. But in South Africa, for instance, we've got a really dynamic leadership at the moment at the national level. And even our minister and DG are going around with tablets, visiting facilities and looking at the data on their tablets and saying, oh, okay, so tell me what happened with your cesarean section rate last month. Why did it drop? The CEOs of the hospitals are having to say, well, if the national level is looking at our data in that way, we better get on top of this data. And to us, that's been very powerful. It's been a real innovator within the department to move people to get serious about the analysis of the data. And even within the annual performance framework that is entrenched within the health system, the DHIS and the NERD, which is the National Health Information Repository and Data Warehouse, allows the department at various levels to do comparisons about performance against a set of indicators. And this has been very powerful in comparing provinces in terms of their performance and being able to drill down from a national level, province through districts and into facilities to identify where are the differences, where are the pockets of facilities or districts that are not performing, and then to zoom into those to try and improve the delivery of services. So that's at one level, and that's at like your higher levels, your national, provincial levels. But one of the key aims of our organization is really to empower health workers at facility level to use information themselves to improve health service delivery. And, you know, we've been talking about technology today a lot, but one of the key things is actually your human resources. So much of it at the end of the day comes down to individuals who get on top of this technology and then make something of it and do something with it. And we've got numerous examples within the public sector where we've got clinicians, health workers, facility managers who are using information to ask questions. why am I seeing so many patients coming in for immunization or for maternity services? Where are they coming from? Are they within my drainage area? Are they outside? Or on the converse, to actually understand, why are we not reaching our immunization targets? Where are our ART patients disappearing to? Why are they not coming back for follow-up? And the information systems that they have at their hands at the moment make that possible. The probability is the next issue. And I think one of the key things that we need to think seriously about is, to what extent are we building the ability to use information into our medical curricula for our doctors, for our nurses? Because I think there's probably some basic medical education happening around the public health arena, but I'm not convinced that it's keeping pace with where technology is going and the potential that that provides us. So I think there's lots of things that we can do with technology, but we've also got to look at how do we address the human resource, the human capacity side of these things.
And that's an excellent point. Peter, I'd like to bring you in at this point and just step away from the HR point for a second, because as well as understanding how to use the data, it's going to be critical to have access to the data. And I know that you've been in these large-scale industries for a long time now, and really we've heard a lot of talk about access to information and silos. And my question to you would be, how do we start planning a long-term framework, data framework that breaks down silos, that uses enterprise-wide scalability? So how do we prepare for that long-term picture? But what do we also do in the meantime? How can we work with the tools and systems at hand to really sort of try and get the resources out of that to do the kind of work that Sean and Vincent have been describing?
So my view, obviously, we're moving to a space of digital area, but no doubt about it, whether you're in any particular vertical. But coming back to the health vertical, the one is actually coming back to your question, is actually to understand the patient first, diagnose him properly, capture the data on the correct systems, have a good platform in place, okay, that's totally integrated, and therefore you can push data through seamlessly from a practitioner to a pharmaceutical, right through even to pathologists as well. I'm just giving that particular view. However, we need to maintain the data as well, constantly as well. We can gather data, we can capture it, and it just still stores it. But if we don't maintain it, okay, then the data means nothing to us. But coming back to Sean's point on a level 5, I think what's important, data analytics or big data really gives us a competitive advantage amongst other role players as well. And that's quite key. So if you do it right, you've got the right systems in place, you've got the right human resources in place, you know how to capture the data, you know how to maintain it, you then got a competitive edge in the market as well.
Peter's absolutely right about saying you've got to start at the patient. But if you look at what's also happening in, for instance, government, the challenge you've got at that level, which is sort of opposite end of the spectrum, is you've got legacy systems which have been designed in a certain way for finance or HR. And now you've got to extract that data from those systems and interface it with your other data, like on your service delivery data, in order to get a more integrated picture. And that's quite challenging because these systems were designed long before we were talking about integration. And they don't talk to one another, they don't use the same codes for their building blocks. And so I think that's actually a very interesting area that we're having to work with. In South Africa in particular, I think we've moved quite a long way forward with the health normative standards framework, trying to set some standard around which in future these systems should be integrating and talking to each other. That's still going to be a challenge in other countries where you don't have those kind of frameworks.
We do have legacy systems. It's how we actually then form the right platform to capture our data. That's what I'm coming from. You're right there.
Taru,
I think, my passion is data standards, and I think without the right standards, your data is going to be meaningless. I think we're all familiar with the term GIGO, which is garbage in, garbage out. So if we don't have the right data standards in place, we'll always struggle to have meaningful analytics. But in the UK, they've done something called do once and share, in that data is collected once and it's shared many times. I think the challenges that we have is we've got different people collecting different data from different points, and it's collected in a non kind of standard way. And then people try and manipulate that data, first of all, to clean it up and then to report on it. And I think you've mentioned that there is a problem with legacy systems. Data migration can be done as long as we define the standards that we want to achieve. Then we can always do a good data migration from all the legacy systems, clean up the data, and then move forward from that. It shouldn't be something that stops us from looking at how we can improve the way we do things now. But the government, I think, needs to take a handle on defining the standards that it requires for it to have meaningful data. That data can then define population disease, and then you can define benchmarking. You can benchmark if you're collecting different data. You can't compare apples and oranges. So you need to make sure that you've got standards, and then you can compare correctly and benchmark.
Thanks, Taru. And I'd actually like you to follow on from that, because I know a lot of your experience has been sort of actually in implementation and deployment projects. You've worked with various solutions, different types of organizations, and from a practical sense, if somebody who was interested in sort of changing how their organization handled data to make it more of a long-term viable driver of benefits, what would you say is sort of the best practice that they need to be thinking about from the beginning to make this work in the long term?
I think from what I heard from discussions this morning, a lot of doctors were saying that they're not involved in the design of systems. And that's the biggest problem, is technology tends to be driven top-down. I think what we should be looking at is what is in it for the clinician, what is in it for the patient. And that is usually missed, and things are driven either by budgets or by some other government initiative or some organizational initiative. And I think we should go back to basics. If I'm a doctor and I'm working in a busy clinic, the last thing I want is some other data collection exercise that doesn't help me with my care delivery. So first of all, I want something that will help me to deliver care more efficiently, something that will help me to get all my information, my blood results, my physiological measurements in one go, so I can make better decisions. So there is primary uses of data, which is what the doctor wants to use that data for. Then there is secondary uses, which is what we want to use for reporting. We can always extract that data from, first of all, it has to be primarily collected for the purpose that it's being collected for, and then we can then manipulate it to do our analytics. So really, we should go back to basics and look at clinicians and say, what are your pain points? Clinicians will tell you, I never have the right information at the right time. I never have my blood results when I need them, and I never have, pharmacists are talking about stockouts. I never have, because the data is not there. It's not being collected correctly.
You'd be a big advocate of involving all stakeholders, particularly the clinical groups, from the very beginning. Absolutely.
The end user should be the driver. I think a gentleman spoke earlier on about the design, that it has to be intuitive for the user. And if systems are being designed in a dark room by a techie somewhere and then being lumped to a clinician, I'm pretty sure it will miss the point. Clinician will look at it and say, I can't use this, and they will shut it down immediately. I think people need to understand that clinicians don't sit behind a desk and tap into things. They are running around, doing things all over the place. And the last thing they want is to, after doing all these rounds, to go and find a computer in an office to enter data. That will not work. So the way we design systems has to understand an environment in which a clinician works in for it to be able to be successful.
May I add something, just to complete the spectrum of our discussion? And it picks up on something Walter Deo talked about earlier, and that's the beware of disruptions that could be coming our way. So a lot of what we've been talking about, which I agree with wholeheartedly, the importance of building these data stacks in the right way, meeting all the right standards. There's an example of where that's been done really well, US and UK, where data records of 11 million patients were extracted. So it assumes there were pretty good electronic medical records in the first place. It was across 9,000 facilities. So there's a whole lot of really hard work already been done, and 11 million records were extracted. Then a bunch of analytical algorithms were applied to identify 62,000 diabetics who had not yet been diagnosed. Now that's enormously powerful. So it didn't need a big screening program. It didn't need a big public health push. It just needed some really clever, granted expensive analytics. And these 62,000 were identified and could be helped. So that's one end of the spectrum. The other end of the spectrum is completely different. And it's a similar public health exercise. If we look at social media, none of us have to go to a doctor and ask them to use social media. Ask them to use Twitter, and please would they have a Facebook account. Usually we're trying to do the opposite and say, please would they put them off in meetings and whatnot. So we don't need to beg them to do that. And yet the social media guys have started demonstrating what could be possible by trying out some preliminary analytics. And I'm sure some of you know these stories of the flu epidemic in the US that was anticipated 2 weeks before it happened by social media analytics. The ICU infection control outbreak, nosocomial infection outbreak in an ICU that was anticipated a week before it happened. So before any swabs had picked it up, the data analytics, the informatics guys that were writing these algorithms were able to say that ICU is going to have this kind of a problem in about a week's time. And then the final one that's also still in early phases is trying to correlation between chatter over social media about risky sexual behavior or ways to avoid risky sexual behavior and the movement of new HIV infections. And it's found with statistical significance to be a good correlation. So this is on the opposite end. This does not need us to have all the standards in place. This does not need us to do a lot of things in the hospital. It's going to happen anyway, and it might just be the kind of disruption that's on its way. So my personal opinion, I think we need both, but we need to keep our eye on both ends of this of the spectrum and be aware of what's happening. And these examples are fantastic examples. On our blog, you can search for them. They're all there.
And Vincent, I'll probably ask you to start us off on that, and that is, when we talk about healthcare data and social media being sort of an unknown in terms of its how personal that information is and how detailed it is. So excluding that side for the moment, looking at the sort of what we consider sort of traditional healthcare data captured by healthcare organizations, it is very sensitive information. There's a lot of personal risks, not just organizational risks to misuse of that data. So in terms of governance, how should we be looking at governance of healthcare data and the ethical sort of not constraints, but the ethical discussions that need to be have around that? It's not just black and white, is it?
I think it's one that we're going to have to get into, and I don't think there's been a lot of discussion about this in South Africa. But I have seen that in other countries they've put forward a completely independent body that actually looks into this kind of issue and looks into how this information needs to be managed. Because we've heard about situations where government gets their hands on this kind of data and people don't like that. From a personal perspective or from an organizational perspective, they might not like that. Yet, government is also a big driver of these personal information systems. And so there's got to be some way of handling this in a middle space, which can then also involve private sector and NGOs and other organizations and individuals that might be interested in pooling their data. So I think having some kind of an external body that's independent, that can oversee this, and then debate the kind of ethical issues and the practices and the best practices is the route to go.
Good answer. And there's good practice for that. My team did a study a few years ago looking at the regulatory side of eHealth across 48 countries in Africa and then 5 best practice countries, including some emerging markets like Brazil and Malaysia. And what we found is that the best practice countries did exactly that. They had an independent body that was responsible for dealing with the whole regulatory side of eHealth. But there are a couple of other remarkable pieces. The first was that we identified 64 different regulatory aspects that need to be dealt with, and 6 of them dealt specifically with privacy. So it's a massive minefield. We then found that in Africa at the time, this was 3 years ago, at the time, we looked for eHealth regulation. So eHealth regulation that was in law, and it's explicitly eHealth, so it dealt with health information. We couldn't find one on the African continent. The good practice countries only covered about 60% of those 64 aspects. So even best practice countries don't cover it all, but Africa didn't have any. Now South Africa has one or two. The one or two other countries, Lesotho for some strange reason also is working on their regulatory environment. But it's starting to move, and the simple answer is it's something you can't keep your eye off that ball. You need to recognize it's necessary. You need to not feel too bad about being behind, because the good practice countries didn't get it all at the beginning and then bring in their eHealth environment. As their eHealth sector developed, so did their regulatory environment improve. But you've got to keep your eye on the ball. You've got to have a framework. You've got to decide what your priorities are, and then start pushing them through.
Preston,
I think just taking one step back is actually, you need to define your corporate strategy of your organization. Governance then follows thereafter. And I totally agree. If we do not have the expertise in-house, rather have an independent body to really actually capture and maintain that particular data. That's in closing remarks.
Taru?
From my experience, patients are quite happy to share data where they know that it's going to be used meaningfully. And sometimes we put information governance as a block for things that we try to achieve. I think, as we all mentioned here, a good policy that makes sure that data is not misused is just what we need. I think other people say, well, we can't share that data, you can't share this, but actually you can, as long as you've got some guidelines and some checks to make sure that it's not being abused. You should be able to overcome those problems.
Thanks, gentlemen. Let's just see if there are any questions from the floor.
My question is about accountability in terms of knowledge management and in the broader sense, because in my experience you have the whole value chain that takes place, but at the end of the day the data, or the information rather, that emanates from the data is not trusted and most probably not utilized. So how can we strengthen accountability measures for the ones that are responsible for the monitoring and evaluation?
Yeah, I can comment on that from the public sector perspective, because that's the domain in which we work largely. South Africa's got a very interesting model where, in fact, on an annual basis, the Office of the Auditor General conducts an audit in a percentage, a sample of facilities in every province, and has a look at what is the value that's captured in the DHIS, in the national system, what's the value that's captured in the monthly summary form, and what's the value that is in the registers. And their facilities are allowed a certain kind of error rate. And based on that, they then issue their report. And this has been really quite a best practice example of a situation where you've got high-level national monitoring of data quality and pushing facilities to really ensure that their data is of a high quality. Because obviously if they don't meet the standard, they get an adverse audit report, and no one wants that. Nevertheless, that doesn't mean that we've overcome all the data quality problems, but it has to be an ongoing process, and I think that's a very robust system. I think the other side of it is that in South Africa, again, a best practice is finance, or actually now Office of the Premier, Office of the President, DPM&E, requires each department, including health, to submit quarterly returns, and that is then used to monitor performance in the provinces and at the national level. And that in turn is also, or the data that is provided by the system is used by finance to allocate money to provinces on the equitable share allocations. In South Africa, we've got pretty robust systems to drive improvements in data quality. In other countries, I think there's very much in the health sector recognition of the importance of doing these kind of data quality audits, but they're not as institutionalized as they are in South Africa.
There's another critical aspect that Vincent was actually one of the pioneers behind, and that's make sure the data is meaningful to the person who's collecting it.
Yeah.
And that's the simplest answer and possibly the hardest answer. Just because it's simple doesn't mean it's easy.
Yeah.
If there's an incentive for me to collect the data and collect good quality data because I can use it and it can help me do my job better and I can feel that that's exciting and I want to be part of that, I'm going to collect better data. And it goes back to the comment made so many times today. Involve users, not early on, but from the beginning. And if you haven't, you better fix that very soon, or it's going to come back to bite you down the line.
Yeah, absolutely.
And I think that's also why patient information systems, electronic patient records, are really important, that the clinicians have an interest in capturing the data directly rather than through an indirect method, first on paper and then someone else does the capturing, because clinicians have an interest in ensuring that that data is accurate because they'll use it when the patient comes back again.
I think what's critical as well, above all said, is where do we store the data? And do we have the right platforms or systems, or let's call it frameworks in place to store the data? That's quite critical.
I think that'll have to be a discussion for another day because I think we're out of time.